because we are way out of time.
So, then the question that I will address to all of us would be, and especially the panel, where are we standing now after all these interesting talks? LASIK is still the most popular refractive procedure worldwide, with more than 40 million procedures done since 1991, although it's declining, and the LASIK trend is showing since 2007, a clear downward trend. So, PRK is reviving due to the trans-PRK module that has been introduced very successfully. More than 1.5 million trans-PRK procedures have been performed the last 10 years. And particularly, it's the hype about combined procedures, trans-PRK with cross-linking for corneal ectasia, that also helps to the boom of this technique. And of course, we have the emerging technique of SMILE, which is expanding rapidly and has not reached its peak yet. SMILE has an FDA approval for myopia. As far as I know, just a pre-market approval for myopic astigmatism, but they expect to expand their indication range, and they have surpassed the 1 million procedures since 2007. So what about LASIK? How are we doing in regards of LASIK? There's a great meta-analysis, maybe the most comprehensive in the literature, 2016, with 97 reviews of more than 67,000 eyes in the study, showing that uncorrected distance visual acuity of 20/20 or better was achieved for more than 90.8% of the eyes. And the target refraction within 1 diopter, plus minus 1 diopter from the target refraction, was achieved in 98.6% of the eyes. Only 0.6% of the eyes lost 2 or more lines of corrected distance visual acuity, and patient dissatisfaction was also very low, 1.2%. So these are fantastic results for the LASIK procedure. And if we move to PRK, the best review article on that was from the group from Bruce with Alex Short in the Cochrane database, showing that PRK and LASIK have actually similar clinical outcomes 1 year post-op. Now, the modification of PRK, the trans-PRK technique, as I mentioned before, was introduced, and it was shown that actually trans-PRK is safer than conventional PRK, but in terms of efficacy, it's comparable. And in the meantime, there have been also other modules of trans-PRK techniques, Smart Pulse, trans-PRK, etc. So it's a technique that's been enhanced over time. And the SMILE technique, there are also few papers with comparisons and literature review on that. For myopic corrections, uncorrected distant visual acuity of 20/20 or better was also achieved in almost 90% of the eyes, which is comparable to LASIK. And the target refraction plus minus half diopter was also achieved in 98% of the eyes with long-term stability, showing actually results comparable to LASIK. And another paper also confirms that visual outcomes and safety profile between SMILE and LASIK are comparable. But what is the problem with SMILE? And here I push a bit towards Vincenzo in the debate SMILE versus LASIK. It seems that LASIK is superior in low and moderate astigmatic correction. On the other hand, LASIK is inducing more high-order aberrations compared to SMILE. So the problem basically with LASIK is that, first of all, we have an indication range which is smaller compared to LASIK. So we're talking only about myopia, myopic astigmatism, and the astigmatic corrections are still a problem with the SMILE procedure. Now, comparing LASIK, PRK, and SMILE, LASIK versus PRK, we have similar visual outcomes, similar retreatment rate, and similar quality of life. LASIK has, of course, no discomfort, faster visual recovery, almost no haze. PRK, on the other hand, is suitable for thin corneas. Biomechanically, is more stable and has no flap-related complications. LASIK versus SMILE, the visual outcomes are more or less similar for myopia. There is a problem with astigmatic corrections in low and moderate astigmatism. Patient satisfaction is similar. However, with LASIK, we have faster visual recovery. The retreatments are easy. And yes, the superiority for astigmatic corrections. The SMILE is biomechanically more stable and has no dry eyes. What about complications? Corneal ectasia is rare, but it occurs, and it seems that the higher incidence is with LASIK procedures. SMILE appears to be biomechanically more stable compared to other procedures. However, the data that we have are based on ex vivo studies, and we don't have long-term data from real life, from real patients, so I would put a question mark here regarding SMILE. Now, we have LASIK-related complications such as epithelial ingrowth, diffuse lamellar keratitis. The stromal haze in PRK is not as big as a problem as it was before. And the regression rate is about 6.3%. It's the same, actually, for LASIK and PRK. Now, the risk for infection is very low. It's a bit higher in PRK procedure. And the dry eye problem, which is actually one of the major complications in laser refractive surgery, is higher in LASIK, less in PRK, and almost zero in SMILE. Now, what about post-refractive ectasia? We know that LASIK has higher risk for ectasia compared to PRK and SMILE. However, there have been described ectatic corneas after SMILE, but almost all of these eyes had a problem in the preoperative assessment. They were eyes with high Radleman risk score, or the PTA was also high, above 40%, or they had form-frust conus. This is something that the authors checked actually later on, after the complication had occurred. Now, the biomechanical profile of SMILE is superior compared to LASIK, but again, we don't have real-time data from real-time patients over a long period of time. And that's why I would say that here there is still a question mark. Now, in terms of corneal biomechanical stability, SMILE and PRK are considered to be equivalent. Again, there is no evidence to support this in a valid manner. What about dry eye syndrome? In LASIK, this is actually the major reason why patients are complaining, and most of the patient blogs where they describe their no LASIK again, or I regret for having done LASIK, they are referring actually to this dry eye syndrome post-procedure. In SMILE, the incidence is low, and there's a good reason for this. In LASIK, when we create the flap, we cut more than 90% of the subbasal nerve plexus of the cornea. On the other hand, the SMILE incision is excising only 10% of the corneal nerves. So there's a huge difference there. Moreover, the SMILE lenticle, which is extracted, is beneath the subbasal corneal nerve plexus. So we leave more or less an intact corneal innervation after SMILE. And there's not been described, at least in the literature, the neuropathic pain, the ghost pain in SMILE patients, which is something that we often see in LASIK patients. We can discuss about it later, maybe, about this ghost pain in LASIK patients. Now, quality of vision, there's an excellent study from Solomon describing, actually, it's a meta-analysis, 309 studies over a long period of time. And it seems that the satisfaction rate for primary LASIK is 95.4%. It's a fantastic number. And surprisingly, for me, the patient satisfaction after myopic LASIK was a bit less compared to hyperopic LASIK. Now, there are very few data on patient-reported outcomes for SMILE, but still the satisfaction rate is high, 95%. Now, during SMILE, patients experience the procedure experience more discomfort. However, the post-op satisfaction is comparable to that with LASIK. And the retreatment rate, regarding retreatment rate, the retreatment rate seems to be less in SMILE, but big question mark, what kind of retreatment if required? So that's another point for discussion. Now, what can we do better? So let's see what we have. We have actually a problem in the hyperopic corrections, where a high number of eyes have a loss of 2 or more lines of vision compared to myopic corrections. And we also have a high percentage of visual loss in astigmatic corrections, between 1 and 4 diopters. Now, the regression rate in hyperopic and high astigmatic corrections is relatively high. And we still have the unknown factor for post-refractive ectasia. What is required to overcome the current problems? Enhancement of the sedation for the hyperopic ablation profiles, torsional alignment for astigmatic treatments, better control of the regression rate by using maybe cross-linking as an additional treatment for the refractive procedures and for refractive stability, and maybe better biomechanical analysis of our patients for customized risk assessment preoperatively. Now, to sum up for take-home message, all 3 procedures have excellent visual outcomes with very good safety profile. The efficacy and accuracy of the laser procedure is being improved. I think that LASIK has reached the maximum in terms of efficacy and accuracy. For SMILE, there is still room for improvement, both in efficacy and for safety. I think things look actually very good. And PRK with the trans-PRK module is becoming again a very good competitor in the refractive market in terms of safety and efficacy. Now, the patient satisfaction is overall excellent. And never forget that we should choose our refractive options based on customized individual risk-benefit profile of every patient. So again, a reminder for our EVER Congress in October in Nice, France. And thank you again.
Thank you, Zisis, for making on time. You finished your talk on time, but you left so many issues open. We can debate all day long for that. I will move on to my talk about correcting post-phacoemetropia with refractive surgery, and maybe later we can have some time to debate on everything we talked about.